Hello everybody. Today we are going to discuss about spinal cord injury. Spinal cord injury remains the significant cause of disability worldwide despite the vast improvement in the conventional therapies. So regarding pathophysiology, cases of spinal cord injury that involves the gunshot or stab injury may result in the complete severing of the spinal cord, but in most cases, patient presents with the anatomically incomplete lesion of the spinal cord with compression or contusion injury being most frequent. So spinal cord injury has been described as developing in three phases. That is acute, secondary, and the chronic. The direct mechanical trauma to the spinal cord injury is quickly followed by the local ischemia and hemorrhage, resulting in edema and neural cell death in immediate vicinity. The term spinal shock was introduced to describe patient's condition following acute spinal cord injury. That is muscle paralysis, flaccid muscle tone, loss of tendon reflex below the level of lesion. Secondary injury is characterized by the dramatic ionic changes in the injury zone after spinal cord injury, which results in the breakdown of the cellular membrane and the release of inflammatory mediators. In the chronic phase of spinal cord injury, a cystic cavity forms that is surrounded by astrocytic scar. In addition, there is degeneration of the axon distal to an injury, as was first described by the Waller. Long-term sequelae following spinal cord injury include chronic pain and spasticity. Now about initial care, the primary effort in the initial phase are focused on the life-saving procedure. The ATLS protocol has broadened the distribution to capture all injuries in mostly unconscious patients. Since hypotension and ischemia perfusion are known factors for secondary injury, step B and C of ATLS protocol, that is early oxygenation and aggressive volume replacement, is highly important. ATLS protocol also emphasizes the log rule in the step E. This is the most critical step in the management of combat spinal cord injury, as there is immediate requirement to transfer the patient to higher level of care. Instability of spinal cord must be presumed in any patient with complaint of sense of instability, vertebral column pain, tenderness in the midline over spinous process, any neurological deficit, and suspected but not proven injury. In case of penetrating injury to the spine, for example, gunshot wound, the local management should not only be done after adequate resuscitation and ABCDE of ATLS protocol. In case of CSF leak, the wound should be sutured after adequate debridement and irrigation, and casualty started on the broad spectrum antibiotic. In neurologically stable patient with fragment in the cervical canal, evacuation with the adequate immobilization and delaying surgery for 7 to 10 days makes dural repair considerably easier and reduces the problems with leak. Now about neurological examination. Classification of spinal cord injury is based on the standardized examination conducted according to the methods described in the International Standard for Neurological Classification of Spinal Cord Injury and the accompanying reference manual. The neurological assessment for traumatic spinal cord injury involves the three part sensory, motor, and the rectal examination. With information obtained from examination described above, one is able to classify the level and the severity of injury. So the neurological level of injury is defined as the most caudal segment of spinal cord with normal sensory and motor function on both sides of the body. Zone of partial preservation refers to those dermatomes and myotomes caudal to the neurological level of injury that remains partially innervated and demonstrated partial preservation of the function. Severity of injury is graded by facial impairment scale as 5 points ordinal scale from A to E. Complete injury is defined by the absence of sacral sparing, namely no sensation in the S4-S5 segment and inability to voluntarily contract anal sphincter. Associated trauma with the spinal cord. So no additional injury occurs in 55% of cases. The fracture of the trunk is associated in the 17% of cases. Long bone fracture is associated in 13%. Head and face trauma is occurred in 13%. Pneumothorax chest injury in 8.8%. Abdominal injury in 8.6%. Then Asia impairment scale, A is complete injury, no sensory and motor function is preserved in the sacral segment, S4, S5. B is incomplete injury, there is sensory but not foot motor function is preserved below the neurological level and it includes the sacral segment S4 and S5. Then C is again incomplete injury, that is motor function is preserved below the neurological level. More than half of the key muscle below the neurological level have the muscle grade that is less than 3. D is again incomplete injury, that is motor function is preserved below the neurological level and at least half of the key muscle below the neurological level have the muscle grade of more than or equal to 3. E is normal, that is sensory and motor functions are normal. Now about role of imaging. The primary diagnostic includes AP and the lateral radiograph of the spine. The additional anterior cervical spine and the odontoid axis film may be required. A higher level of the care, severity of the spinal cord injury is accurately assessed by the magnetic resonance imaging. Characteristics shown to be related to the prognosis have included presence of intramedullary hemorrhage, presence of edema, length of edema, and cord compression. In addition to the diagnosis of spinal cord injury, imaging on MRI are related to the neurological recovery and the functional capabilities following spinal cord injury. Now about management. Management in the acute setting can be divided into effort to treat and impact outcome following acute spinal cord injury and management of the acute medical condition. Now effort to treat and impact outcome following acute spinal cord injury. Only methylprednisolone is routinely administered in acute clinical setting. Presently, efforts have focused on rehabilitative strategy and optimizing medical management to prevent secondary complications. Now about steroid. For the treatment of traumatic spinal cord injury, high-dose methylprednisolone therapy is only pharmacological therapy reported to have efficacy in phase 3 randomized trial. It is indicated if the patient presents with the neurological deficit within 8 hours of injury and is administered as an intravenous bolus 30 mg per kg over 15 minutes followed by 45-minute pause, then continuous drip of 5.4 mg per kg per hour for 23 hours. Then management of the acute medical condition, deep vein thrombosis and pulmonary embolism. The occurrence of the DVT and pulmonary embolism are among the most feared complications during the acute period. Without prophylaxis, 47 to 100% of individuals with acute spinal cord injury will develop DVT and PE, the third leading cause of death. Pharmacological prophylaxis should be initiated as soon as possible, preferably within 72 hours of injury. Now, autonomic dysreflexia. Patient with the neurological level at and above T6, they are at risk for life-threatening complication called autonomic dysreflexia. It is characterized by the abrupt onset of malignant hypertension following noxious stimulus. Now about respiratory complication. Overall respiratory complication are the leading cause of mortality during the first year post-injury as well as during long-term follow-up. Now about pressure ulcers. These are the devastating complication that occurs in up to 40% of spinal cord injury patient during initial hospitalization. Then bowel dysfunction. Because of autonomic dysfunction and immobility, gut transits time are prolonged, which in turn can predispose to severe constipation and impaction. In addition, volitional control of the defecation is often absent with severe injury. Then bladder dysfunction. Urinary retention is the primary voiding abnormality during the acute phase of spinal cord injury. It is prudent to maintain indwelling catheter until the patient is transferred to the rehabilitation center. Now the surgical treatment of spinal cord injury. Surgical treatment can range from simple limitation in the activity of external orthosis to the open reduction and internal fixation with spinal instrumentation. The goal of threatening this injury is to utilize least invasive surgical technique to stabilize an injured segment while limiting the potential for subsequent catastrophic neurological injury, progression of deformity, and the chronic pain condition. Now, external orthosis. Numerous external orthosis options are available for the numerous spinal cord injury. For cervical spine, option ranging from least to the most restricted care, that is soft and hard cervical collar, cervical bracing with the addition of thoracic waist, and the hollow waist immobilization. In thoracic spine, the rib cage provides the some natural support for thoracic spine fracture. In upper thoracic region, that is T5 and above, is very difficult to immobilize with external orthosis. Hence, patient is immobilized with the hollow orthosis with the long thoracic waist. Spinal fracture from the T6 to L2 are locally typically braced with the custom molded hard shell orthosis, that is thoracolumbar sacral orthosis, or with more versatile adjustable fit braces or clamshell brace. Below L3, lumbosacral orthosis is used for support. In addition to increase immobilization at lumbosacral junction, leg extension can be fitted to orthosis to assist in limiting motion across the pelvis. Now, surgical option for traumatic spinal cord injury. Controversy persists in the surgical community regarding the optimal treatment of many traumatic spinal injury, especially regarding timing of the surgical intervention and type of the surgical approach. Surgical intervention is often advocated to decompress neural element, prevent possible late neurological injury, correct and prevent deformity, and provide early immobilization. Spinal instrumentation is the method of straightening and stabilizing spine after spinal fusion by surgically attaching the hooks, rods, wires to the spine in a way that redistributes to the stress on the bones. Anterior, posterior, and the combined anterior posterior approach can be used to treat traumatic spinal instability. Anterior approach may be favored in situation where herniated disc or the bone fragment is causing ventral compression on spinal cord, or in fracture pattern where integrity of the anterior column of the spine is significantly compromised. Posterior surgical approach and the instrumentation typically allow for better reduction when deformities are present and may benefit in restoring the posterior tension, Barney distraction type injury where there is disruption of the posterior ligamental structure. In translation injury, where there is severe circumferential disruption of spinal column, combined anterior and posterior instrumentation procedure may be used. Intraoperative imaging is often used by surgeon to confirm appropriate level for surgery and improve the accuracy of spinal instrumentation placement. Thank you, guys.